Welcome everyone, thank you for coming today. I'm going to give you a little bit of just my experiences with the BioFire panels that we use at the University of Kentucky, and welcome to any questions at any time. And I'd like to thank BioFire for letting me come tell them some of my experiences. So the first thing to understand is that this is a lab test. So anytime we use a new lab test in the emergency department, I think the first question we ask ourselves is, what makes this test better or different than what I'm using already? So the things that matter to me: does this test answer a question I need or want to know, and does it answer it faster than it usually does? Then I usually get an answer. Everything in emergency medicine is about disposition time and how quickly we can get the patient either upstairs or outside, back home. And then there's sensitivity. In emergency medicine, we care much more about sensitivity than even specificity, because that's where we have the least false negatives, we're making the least potential mistakes, and patients are the safest. If there's a high specificity, that's a bonus on top of that. And as you'll see, the BioFire panels are actually very sensitive and specific, so you really have both sides. And then patient satisfaction, and I think that's probably one of the best parts of these panels, is that it really improves patient satisfaction finding an answer to their illness. And then cost, of course, we always factor in cost whenever we're looking at any new test, and so certainly making sure that we're not ordering the most expensive test is part of what we use to decide. So just real briefly to understand what BioFire is, and as Steve mentioned, it's a rapid PCR. Different than the PCR, at least that I learned about when I was in medical school and in undergrad. It's far more complex than that. It's a multiplex PCR machine that tests for infectious disease. But what's probably most important is just how easy it is to actually do. It takes about 1 hour for all of these panels to be done. Now, nothing in emergency medicine ever happens quite as fast as we want it to, but the actual lab part takes 1 hour. Now, getting the lab the specimen to the lab, getting the lab to actually start the machine, and those things always factor in. But all the tests take 1 hour and require only a few minutes of hands-on work for the lab tech. So these are actually very easy to do and very quick to run. So the first panel, just to go over each of the panels briefly, is the respiratory panel. They now have the RP2 panel, and as you can see, the sensitivity and specificity are extremely high, 97 and 99%. So really helpful in just how accurate they are. And these are very easy tests to obtain. It's a nasopharyngeal swab, so you can obtain it very easily on both kids and adults, and it tests for these 21 viruses and bacteria. Some of these are very important for us and helpful in managing our patients, such as influenza, RSV, pertussis, mycoplasma. Some of them may not seem as essential to know, but are often very helpful in giving the patients more information about what they actually have and what their next few weeks will be like. And then some of the initial studies done by BioFire or at some of the university hospitals around the country, they found that the ICU days actually decreased from 9.2 to 6.2 days after implementing the BioFire panel, respiratory panel, and the amount of antibiotic use actually decreased by about 0.5 days because you now found out much quicker what exactly was causing the infection. And both whether the test was positive or negative, it actually saved the hospital money because you actually found out just exactly what you need to do much quicker in the patient's care. So my personal observations with the respiratory panel, more important to me than what happened even upstairs for these patients, was actually how I was able to use it to increase discharges. So many of our patients, especially in a tertiary care center, are coming from other institutions. They're coming after multiple visits at other places, and they often are just frustrated. What's happening? Is my child sick or my family member sick, and do they need more treatment than they've received? And so this was a much easier way to give them a final answer of what exactly was causing their illness. It was a great way to avoid antibiotic use and all the potential complications from antibiotics. And even when we did admit patients, they often would try to cohort the patients to the same area. So all the flu patients were on one side, all the RSV on the other, and so forth. It also helped us do less unnecessary testing because now we had an answer, so we didn't have to do that lumbar puncture when we were debating whether this is meningitis or a respiratory illness causing the fever. And then as the anti-vaccination kind of has become much more popular throughout the country, we found that the pertussis was very helpful too, as there was much more pertussis than we used to expect, and our previous test was actually a send-out for pertussis, so we really just had to treat based on symptoms without having a clear-cut diagnosis. Next is the GI panel. This has about a 98.5% sensitivity and 99.2% specificity. Obviously, it's a stool sample, and you can see all the different things it checks for, many of which are treatable infections and that require antibiotics to get better faster, as well as some of the parasites. So stool samples in general are never very good. The diagnostic yield in general is very low. As you can see, it's 18% for the classic way we send stool samples looking for culture, O&P, and white blood cells, and you really don't get the answer very often, only about 18% of the time. With the BioFire panel, the diagnostic yield actually increased quite a bit to 54%, so you're able to actually get a diagnosis much more often. My personal observations from the GI panel is that when we were able to do this, when the patient came with a week or more of diarrhea, we could much easier do just the GI panel and avoid doing all the other tests that really weren't going to help, like the labs, the X-ray or the CAT scan that really didn't make a difference in the patient's care. We were able to focus on the actual problem that they were having. So there was less imaging, less admissions, less delay in getting a diagnosis, and much happier patients and family members as they got a diagnosis. The way I use it is I usually wait for the patient that's had symptoms for at least 7 days, and or if they've had some confounding factors, like if they've traveled, they've been in the hospital recently or immunocompromised, been exposed to antibiotics, well water, bloody diarrhea, something like in that side. And then the next panel that we use quite a bit is the meningitis encephalitis panel. This is actually probably been the most helpful panel in really helping patients with something that's actually very critical to their health, as we much needed to find out what's causing their meningitis much earlier in their care. This has about a 94.2% sensitivity and a 99.8% specificity. So again, a very accurate test, and a test for obviously all the things that we typically are looking for in the US, in particular for viral and bacterial and fungal meningitis. So traditional testing takes about 13 hours to get any kind of culture results. If you've sent up CSF, you kind of have seen that probably very often. The BioFire panel on average took about 3 hours, and again, the panel itself really only takes about an hour to get results. It's the lab and the delay in just getting the sample to the lab that sometimes takes a little more time. But the diagnostic yield here is extremely high, 96%. So virtually almost every time you're going to get an answer when you send true CSF up to the lab for meningitis or encephalitis. So personally, this has helped in our institution quite a bit, as we do a lot of lumbar punctures, both on the pediatric and adult side. There's no more confusing CSF results trying to interpret whether this is viral or bacterial meningitis when the cell counts are not as high as you expect. If they've been partially treated with antibiotics, as it seems like most patients usually are, it doesn't matter. It still will come up positive for whatever they have, which is almost always the case, that they've been partially treated. And now when we find out they have viral meningitis, particularly things like enterovirus, we can send them home instead of admitting them to the hospital, and they can do supportive care at home. So you're actually saving quite a bit of money for the hospital, the patient, the system. It's less antibiotics, less antivirals, and less use of just overall resources such as consultants, isolation rooms, and the ICU. And it really answers probably one of the true emergencies that patients come to the emergency department with. What is the cause of my fever and headache? And one of the things people are always worried about is meningitis. Next is the blood culture panel. This panel is about 98% sensitive and 99.9% specific. This panel I have a little bit less experience with. It's done after the culture has been already positive, and then it's sent for this panel, which takes about an hour to result. So obviously, cultures don't come back that fast while the patient's still in the emergency department, but we often get some follow-up on these patients, and you can kind of see the different things that it can test for, both fungal as well as bacterial, as well as some of the resistant genes that we see. And as you can see, the panel has helped quite a bit in making sure that the patient's on the right medication. So about 36% of the time it narrowed the antibiotic selection, 17% of the time it actually expanded the antibiotics as it was found that they were not on the right one, and about a quarter of the time it didn't make any change. But it also avoided a lot of return visits. All those contaminated specimens are now much clearer, much earlier in their care. So again, this has been shown to reduce hospital costs, decrease the amount of billing per patient, and save healthcare dollars. Personally, I've seen this be very useful in patients with sepsis, neutropenic patients, endocarditis, where it's often polymicrobial and often fungal, at least in our population, and it gets the right antibiotics much earlier in their care. It really eliminates treating contaminants, escalates and de-escalates the choice of antibiotics much earlier, and adds antifungals much earlier in the care as well. And the last panel I was going to describe is the pneumonia panel. This is a relatively new panel for BioFire that is performed off either BAL samples, most likely performed by the ICU or pulmonary, sometimes critical care physicians in the emergency department, or sputum that can be obtained through an endotracheal tube. And you can see the wide array of virus and bacteria and atypicals that it can check for. So if you look at this graph, typically you only catch about 16 or 34% of the respiratory cultures will be positive when in our classic respiratory culture, but when you add the BioFire panel, the 22 and 27% are added to the 16 and 34 as far as how many positive results you're going to have. So you get a lot more positives and realize what exactly the patient really has much earlier in their care. So again, this is potentially useful for trached patients that you can do a deep suction through their endotracheal tube, or patients that are being bronched in the hospital, either in the ED or upstairs, depending on what kind of institution you work at. Far better than just a respiratory culture alone, and it's much better in helping pick the right antibiotic much faster. I'm just going to go over a few cases of patients I've seen as well. So the first case is an 85-year-old female who presents as a transfer from an outside hospital with 5 days of fever, altered mental status, and rash. No clear source had been found, and the family reported she was much more agitated than normal. Significant history, you can see she's a diabetic, nursing home patient, demented, and has been recently treated for UTI. Family's really upset. Nobody likes seeing their family member look different or altered from their baseline, and so they're very frustrated of what's going on. The patient herself, elderly female, very agitated, combative, hard to control, and she has a really concerning rash, petechial and purpuric rash on her legs that as soon as we saw, we were worried about the etiology of her infection. Some of the labs that had been done prior to even arrival at the outside hospital included are listed here, as well as her vitals. As you can see, she's showing some signs of sepsis. Her heart rate's elevated, her blood pressure's a little on the low side. She's obviously got a fever, and she's tachypnic. Her white blood cell count's elevated. She's already showing some platelet dysfunction. Her kidneys are starting to have injury as well. And she does have a mild UTI, but probably not enough to explain all of her symptoms. X-ray's negative, and prior to arrival, she had been given a gram of Rocephin at the outside hospital. So on looking through the records of this outside physician, we could see that they had attempted to do an LP. They obviously had the same concerns that we did of potentially meningitis, and they were unable to do the lumbar puncture due to the patient's general agitation and movement and not being able to keep her still. So we realized pretty quickly that we needed to get this lumbar puncture done. She was fairly sick and was only going to get sicker, so myself, the tech, the nurse, and my resident kind of held this patient in position, sedated them a bit, and went ahead and did the lumbar puncture. And the fluid we obtained, something like what you see in the middle there, very obviously purulent CSF that we quickly realized was obviously meningitis. There was no debate about it. And so everyone kind of was very worried at this point of what kind of meningitis we might be dealing with, causing this kind of rash as well. kind of the classic teaching when I trained. When we sent up CSF results, we obviously looked at the white count, the protein and glucose level, maybe the opening pressure, and there's a lot of maybes and most of the time kind of answers on this chart of when to decide whether someone has viral versus bacterial meningitis. And so, we always kind of treated everyone as bacterial meningitis and then waited for the cultures to grow out negative over the next 24 to 48 hours. Everyone kind of got the shotgun approach of treating for bacterial and maybe even viral with like HSV before the cultures grew back. So then putting it all together, the resident and I decided, fever, altered mental status, rash, a purulent CSF. The big bad wolf is obviously Neisseria, meningitis, and gram-negative diplococci, and we were worried that this patient had Neisseria. And at that point, we were debating whether to broaden the coverage, start prophylaxis for everyone who had been exposed to this patient, because not only had all of us been exposed, but the EMS crew that transported her, the outside hospital, the nursing home she was at, they were all potentially exposed patients. And of course, what kind of isolation she would require now that we had a potential diagnosis. But with the BioFire panel, in about an hour, we were able to make the diagnosis of strep pneumo meningitis, which thankfully meant we didn't have to take prophylaxis. There was not any isolation required, no antifungals, no antivirals. The ICU team had a much clearer path of what they needed to cover, and the family was much happier, at least knowing exactly what she had and what the next steps were and what the likely outcomes would be. Next case is a pediatric case of an 8-year-old with 2 weeks of vomiting and diarrhea, occasional abdominal pain, vomiting about once a day, and mostly just watery, non-bloody diarrhea about 2 to 5 times a day. Initially seen at an urgent care and by the PCP and started on ranitidine. No real improvement, and so obviously presents to the ED at some point. Review of systems was essentially negative, no real past medical history except constipation. Past surgical history, nothing. Family history is none. And the vital signs are stable. The child is pretty well appearing non-toxic and with just a little bit of abdominal pain. This was actually seen by one of my partners and one of my residents who told me a little bit about this case, but they just felt this pressure to do something because this patient had been seen multiple times and was having prolonged episode of diarrhea that wasn't really resolving. So they obtained some of the usual labs, none of which really showed any significant abnormalities, gave some IV fluids, and then eventually decided to send the comprehensive GI panel, which is our BioFire GI panel. And it was positive for Giardia and made the diagnosis and gave the family much clearer path of what to do next, which was flagell for about a week. And the last case I'll talk about is a 19-month-old with a fever. So this is a 19-month-old female who presents with fever for 6 days, cough, congestion, eating less, normally healthy, shots were up to date. As most ER visit patients come, they usually aren't the first doctor to see that patient. So this patient actually had been seen at urgent care at the beginning of her illness, and they did a strep and flu swab, both were negative. She was discharged with instructions to go to the ER if the fever gets higher, symptoms do not resolve, kind of the classic discharge instructions. Second visit, gets seen by the PCP, still essentially the same symptoms, fever, cough, some vomiting, decreased urination. PCP diagnoses them with otitis. I think you guys know that we see that often when the pediatricians see patients. They start them on amoxil if they feel like there's an ear infection. Unfortunately, that just added diarrhea to the symptoms that this patient was having. So by the third visit, you have the angry mom who's frustrated that this kid's not getting better while on antibiotics. PCP tells them to come to the ER this time. And this time in the ED, they obtain a bunch of labs, urine, chest x-ray, give IV fluids, Tylenol, Motrin, but really don't find a clear diagnosis and send them home. So on the fourth visit, now angry grandma's coming with them, and they're not going to go home unless there's an answer. And this happens often, at least in our pediatric population. By the time they come to our university ER, they want an answer, and they're not really happy to leave unless they've got some sort of diagnosis. And so this time, rather than repeating the same labs that have just been obtained, we did the respiratory panel, and we made the diagnosis of adenovirus, which again, isn't life-changing in a diagnosis, but definitely help the patient, the family, or really the family more than anyone else, get a clear answer of what exactly has been causing this prolonged illness and what the expected course would be. So in about an hour, now you have a much happier grandmother. She's got an answer and something to Google at home, something that they can look up and get some discharge planning for. So that's everything I was going to discuss it, but I want to open it up to any questions you have for me or the BioFire folks about their panels or their technology.